All right, so moving on, and I did upload cardio part 1, correct? Has access to it. Perfect, fantastic. The objective. Cardio is going to be broken up into 4. I'm trying to decide just how far or what's going to actually be on the test, whether or not I'm going to put part 3 on this test or the next test, because again, remember how we had to kind of shift things around a little bit to give antibiotics a little bit more room to breathe there. So I'm still trying to figure that out, but at the very least, part 1 and 2 of cardio are going to be on this test. Part 3, maybe plus or minus, we'll see, but I will make that very clear to you as we're moving forward, okay? Anyway, first off, let's talk a little bit briefly about cardiology as far as antibiotics go. So which infection do you think with cardiology we would need to worry about? And that's the primary thing we're going to be talking about today. What is endocarditis? Infection of the valve, right? You get this nice vegetation that forms there on the valve. Who might be at risk for that? IV drug abusers, right? So those are a big group. Who else? Yeah, potential patient may have like rheumatic disease or something, had maybe damage on the valve. What else? Valve replacements are another big one, right? So anytime you're again putting in a foreign material, that can act as a nice location for bugs to want to start to grow in there. And again, why are these infections hard to treat? You think it's right there in the bloodstream, like you should be able to get antibiotics there, no problem, right? Well, I mean, blood's all going through the heart, right? So you should be able to have access to the valve. So the vegetation is really hard to beat. So they basically is kind of like building up a nice kind of barrier around themselves. It's very difficult to penetrate through that barrier. And again, if you cannot eradicate this with the antibiotics alone, what do you have to do? Yeah, you have to replace the valve, right? So again, we want to prevent that, at least from my standpoint. We're going to be looking at the antibiotics to help prevent that. But especially if you have like a mechanical heart valve replacement, you develop endocarditis, oftentimes you need more surgical intervention to get rid of that, right, and replace it. So another thing to note here as well, with patients with poor dentition, you have to worry about dental infections, and oftentimes patients who have a heart valve replacement, we also have to think about prophylaxis for trying to prevent endocarditis. We'll mention that in just a few seconds here. Again, not super common, but when it does occur, you want to be able to catch it pretty promptly there. And again, as I mentioned, they had this thrombosis forming on that, any kind of abnormal endothelial surfaces there. You get the secondary infection, and then they form that vegetation on the surface, and that is what makes it very difficult to penetrate through there. And as far as causative bugs go, you're going to find there's a pretty wide variety of things here. Note as well that the history is going to also influence what could be involved here. So, for instance, an IV drug abuser may have a different sort of spectrum of bacteria that could be causing disease versus someone who maybe had no previous history, right? So we'll talk about those as we talk about in a few minutes here. Staph and other gram-positives are going to be the big ones. So like Staph aureus, about a third of cases here. Viridin, strep, and enterococci are going to be big causes here. And again, antibiotic therapy is going to be dictated towards which bugs come back in the culture, right? So you're going to start with empiric therapy initially, get the cultures back, usually from a blood culture, and then determine based on what it grows, what antibiotics you're going to be using for these patients, right? Anyway, so as I mentioned, therapy should be geared towards those cultures. This is typically something that requires pretty long treatment for the most part. So again, you need to think of a normal infection, you treat for how long? 7 days, 5 days, 7 days, 10 days, 14 days maybe. This is maybe up to 6 weeks, right? So again, this is pretty long compared to, because again, you need that kind of constant exposure of that vegetation to the antibiotics to really start to penetrate through and kind of break that down, right? Now, because again, this is going to be kind of exposed to the blood, you're going to be able to find with blood cultures, you get cultures back pretty readily and growing something. And again, when would you want to get the cultures? Before you give the antibiotics, right? Because otherwise, if you don't grow anything back, you may think, well, it must not be bacterial. Well, look at the timing of things, right? As I mentioned, our empiric therapy is going to be geared towards covering a lot of those gram-positives, so the enterococci, MRSA, MSSA, things like that. And then based on how the cultures come back, you scale down and use something with more narrow spectrum there, right? So again, what's our kind of workhorse go-to MRSA covering drug? Vancomycin, right? So vancomycin is great. It's going to cover all those gram-positives that could be causing infection here. And again, very good gram-positive coverage for MRSA specifically here, okay? Now, if you stuck with MRSA, say that's what cultured back and use vancomycin, again, I mentioned 6 weeks you may be treating here. There's some ways to shorten that up. Anyone know what that is? Talk about gram-positive synergy here in just a minute, but we'll talk about adding on another drug that can actually help to shorten down that duration of therapy a little bit. Now, if you grow back and it comes back as being something like viridin streptococci or streptococcus bovis, you can actually find that these remain very highly sensitive to penicillin. And so in these cases, we can give penicillin G, right? So go back to the most narrow spectrum ones that we have and just give pen G. And what's kind of interesting is you may find these patients actually being on a continuous infusion of antibiotic. You give it a certain dose per hour for 24 hours continuously in order to make sure you get kind of constant exposure. Because again, what type of killer was penicillin? As far as, was it concentration, time dependent? Remember, it was time dependent, right? So you want to stay above that MIC. You want to be able to keep those levels high for as long as you can, and it's pretty easy to do with a 24-hour continuous infusion. Now, what's the drawback of doing a continuous infusion like that? Logistically speaking. Not necessarily expensive, but your line's tied up, right? So again, depending on how good of access your patient has, sort of how many IV lines they have, in some cases you may only have one line you get into a patient, and so again, tying up that line may make it very difficult to give other antibiotics, to give other medications, give fluids, things like that. So these are things you have to consider as far as access goes for your patients, right? So maybe say, hey, they only have one peripheral access. Maybe I need to talk about getting a central line put in this patient or something else to try to increase the number of lines I have available to me, right? So logistics are very important to think about. Anyway, other alternatives, you could do something like Rocephin. Rocephin is what class of antibiotic? Third generation cephalosporin. That will have good coverage. Now, will that cover MRSA? No, but again, this is going to be where we're going to be streamlining therapy based on how results are coming back, right? You could use vancomycin if they're penallergic and they could not receive a cephalosporin. That could also be used as well. And imagine, remember, how do we monitor for the efficacy of vancomycin? You know, talk about using trough levels, and this is one of those cases where we may actually be shooting for a higher trough. So make sure you look based on the indication what levels you're actually shooting for. Because again, for say like a routine bloodstream infection, I may be able to shoot for lower levels, but with something like this vegetation, it's hard to penetrate. I mean, you're actually going to be jacking my dose up higher in order to get those levels higher to make sure I can get a good penetration there. So it's something to consider. Now, one thing we can do is gram-positive synergy, and that's going to be with the drug gentamicin. Now, why does this seem counterintuitive? Gram negatives is the only real coverage for gentamicin and the other aminoglycosides. So it says, well, why add this on? Well, in these cases, you may find that by having something like a cell wall active drug like Rocephin or vancomycin kind of breaking down those cell walls, maybe you can have something like gentamicin kind of come in and still have some activity against the protein synthesis there, right? So when actually what you find is you can give a shorter course, you know, say 2 versus 4 weeks as the case may be, and get that patient out of the hospital that much sooner, right? So that can be a good thing. Again, the less time you spend in the hospital, the healthier you're going to be generally because you worry about secondary infections and things like that. However, who do you have to worry about gentamicin in?
Pregnant women.
No, maybe not pregnant women necessarily, but as far as what kind of toxicity do you worry about with gentamicin? Ototoxicity, renal toxicity. So they have poor kidneys to begin with. Those are patients you want to be careful with, right? Because again, they can be more susceptible to that as well. Now again, other streptococcal species, again, you're following your cultures there, so we will again get those results back and you kind of look to see what's sensitive. You look for the most narrow spectrum drug you have and just go with that for the most part. If you have enterococci, this is going to be growing here. Generally, you can use penicillin. Again, sometimes you can actually get that synergy of gentamicin plus penicillin. As I mentioned, you don't always have, or rarely do you need to double cover for bacteria. This is one of those cases where you do double cover, right? What was the other one we always talked about? Pseudomonas, right? But again, this is going to be using that synergy to help us get better kill, shorter durations of treatment there. Okay. Now, if it goes back MSSA, obviously we can get away with something more narrow spectrum like nafcillin, oxacillin. If they couldn't receive those, like cefazolin would be another good option. Cefazolin being what kind of antibiotic? It's a first-gen cephalosporin, right? So that's the most narrow spectrum out of the cephalosporins we have there. And then again, plus or minus gentamicin. Of course, MRSA goes back. Vancomycin is good. If it was, say, resistant to vancomycin, what else could I use? Maybe daptomycin, that might be a good option there. What else? Linezolid would be the other one, right? So those are kind of the two big alternatives, I think, to vancomycin there. Usually you don't need to do that, but in case you did, you can at least think of some other alternatives. And if you had some of these haystack organisms here, these are gram negatives, you're going to find this is relatively low cases here. Oftentimes, if we can get away with using something like either ceftriaxone, we can use ampicillin sulbactam. So sometimes they will be producing beta-lactamases that will make ampicillin by itself not useful, or something like Cipro can be used occasionally. But again, this is going to be after. You may start them on vancomycin, realize that it doesn't have any activity against one of these organisms, and have to switch it completely, right? Okay, so looking at IV drug abusers. This is from my Snapchat this weekend. Just kidding. Just kidding. So with IV drug abusers, oftentimes the problem is that how sterile do you think their technique is when administering IV drugs? Not great, right? So there are going to be things like saliva that's being incorporated here. They're sharing needles with people. You know, if they're crushing pills and injecting them, you have to worry about particulate matter from those pills being caught. You can actually have pulmonary emboli that can develop from the products there. But anyway, so again, they're going to have things like skin flora being involved here. So it's very, very different sort of, you know, kind of thing you're treating here. Again, the microbial spectrum is going to be a little bit different based on that. So again, you find much more often Staph aureus is going to be the causative organism here. This is where you have to start worrying about things like gram negatives. You have to start worrying about fungi being involved here, because again, sharing needles kind of predisposes you to what kind of diseases. Things like HIV, and HIV does what to your immune system? It's going to knock it down, right? So again, depending on the patient, you may have someone who has a more progressive HIV/AIDS. You may find that they have pretty poor immune system. Fungi may be something that's involved here, right? So again, just kind of keep that in the back of your mind when dealing with these kind of patients. So very frequently, looking at prosthetic valve endocarditis, you know, they have a lot of failure of the antibiotics themselves. That's why the surgery is required in a lot of cases there. And again, most of the time you can use pretty similar treatments between the two. Again, starting off with Vanco as a you know, as empiric therapy. If you have Staphylococcus come back, sometimes they'll use triple therapy in this case. So again, rare that we do that. They'll use something like a cell wall inhibitor, like, you know, say a Penicillin, an Ansef, or vancomycin. We'll then add on gentamicin, and then we'll add on a third drug called rifampin. Anyone ever heard of rifampin before? It's kind of the first mention we'll have of it here. But we'll talk about that third drug in just a second. And then, of course, if it grows back MRSA on one of these prosthetic valves, that usually does require surgery. So rifampin is kind of a unique ability. They are able to better kill some of these staph that are growing on, that are kind of adhered to foreign material, right? So again, whether it be an IV drug abuser or the prosthetic valve or something like that, there's any kind of foreign material, it's going to have a better time killing that. Now, resistance does develop pretty quick to it. This is why you want to start rifampin last. So what you'll actually do is start off with vancomycin, add the gentamicin, and then rifampin would be the last drug you'd actually add on there, and that helps to limit the resistance you'd actually develop. The way this is going to work, it actually works on the RNA polymerase. It's kind of a unique sort of mechanism we haven't really seen before. Other uses that you will find for it include TB. TB is probably the most common place you're going to see rifampin being used in a quadruple drug regimen, typically. But for endocarditis, is used occasionally. Now, one thing to note, kind of the unique side effect, what do you know about the color of the drug? It is bright red when you actually get it, or actually it's kind of a dark red when you get it into solution. You're going to find that this is also going to cause discoloration of all of your patients' you know, different excretions, right? So the urine, the feces, the sweat. Anytime you're changing the color of someone's pee or poop or sweat or anything like that, you want to let them know, right? Because I had a traumatic experience when I was a young child. I don't know what they were giving me, but I remember no one warned me that I was going to have orange urine, and then I had orange urine, and I was very concerned. I went screaming to my mom and said, "Oh my gosh, I'm dying." She said, "No, it's just medicine we gave you." I was like, "Oh, well, it would have been nice to know beforehand." I don't know what they're treating, but anyway. So yeah, so always be aware of that. Again, we'll talk about other examples of drugs that can change the color of certain excretions as well later on. We'll always know. Anyway, so in some cases you will try to prophylax against endocarditis. This is going to be for patients who are pretty high risk, such as those with like a prosthetic valve already in place, have a history of infective endocarditis, things like that. And in these cases, what you're going to do is give antibiotics prior to any kind of procedure or something where they may have a potential exposure to one of these bugs here, right? So that way you can try to prevent any bacteremia, any vegetation from starting in the first place. So most often you think about this as being with dental work. So again, not like a typical cleaning, but if you were to have, say, like a root canal, if you were to have something more invasive, a tooth extraction, anything like that, that's where you worry about some of the mouth bugs getting into the bloodstream and causing one of those vegetations to begin, especially anything with gingival tissue manipulation, anything like that. So other things would be, you know, if you had like a, say, like a tonsillectomy, anything with the respiratory tract could also be another case you want to think about that. So what you do is you have the patient actually take 30 to 60 minutes before the procedure, you have them take a dose of amoxicillin, okay? You may have them continue maybe up to like 24 hours worth of therapy, may just do the one-time dose. It depends on kind of how high risk they are. But this is very similar to what you would do with a patient going in for surgery for, say, you know, lap chole or something like that. You give them antibiotics within the hour up to the time before the procedure, and that helps to prevent any infection from occurring in the first place. Okay, if they were allergic, you could use an alternative like clindamycin, azeth, or anything like that. It's going to help to get some of those kind of wimpier gram positives. Okay, so any questions on that so far? Okay, let's see what I can cover as far as our lipid lowering agents go. Why do we care about lowering our lipids? Atherosclerosis, that's a big reason, because atherosclerosis leads to heart attacks, right? Leads to heart disease, right? All kinds of, leads to a lot of inflammation, leads to all kinds of problems. So where do we get our lipids from? Diet's a big one, right? So we're going to get it from our diet, and then also from, yeah, our body can actually make it. So we're going to be looking at kind of two sources for these dietary fats. We're going to be looking at ways that our body's going to be producing these and how we can actually interrupt that with medications, as we'll see. And again, with things, with a lot of the cardiology-based problems, typically drug management is going to be the cornerstone of therapy here, right? So again, you're thinking about hyperlipidemia. Obviously, diet's going to be playing a big role. There's a lot of non-pharmacologic stuff that goes into play. A lot of patients do end up resorting back to needing pharmacologic therapy, though. So as I mentioned, the diet usually is going to consist of some amount of triglycerides and cholesterol coming in. What you find is that as these get absorbed through the GI tract, this is going to get incorporated into what we call chylomicrons, okay? And so this is a combination, it's kind of a fat molecule that has both triglycerides and cholesterol in them. And depending on the ratio, you're going to see that as the ratio changes, this is where we're going to start to produce things like our VLDL. So we're going to produce things like our LDL, why is LDL important? That's your bad cholesterol, right? And then eventually it can turn up into the good cholesterol, which is HDL, right? Exactly. And so you're going to find these proportions are changing over time as the body is making these. So anyway, looking at how exogenous fat is going to be coming in, of course we have dietary cholesterol is going to be coming in. How do we get that dietary cholesterol kind of broken down into smaller pieces? We're going to use that using our bile salts, right? So again, as we start to have biliary cholesterol is going to be coming in, helping to emulsify those, you're going to have some reabsorption. What was that process called where we had things getting secreted into the GI tract and then being reabsorbed? That enterohepatic recirculation, remember that? Remember how we can have bile salts that are going to be excreted to the GI tract, and they'll get absorbed, and then they can be eventually spit out again as bile salts. That's going to be an important process for one of the types of drugs we'll talk about, where it can actually cause an interruption to that system, as we'll see in a minute. But anyway, as it gets absorbed to the enterocyte, that's where we're going to have the chylomicron actually be formed there. So basically what you're going to find is that as the chylomicron gets secreted from the intestinal cells, you're going to find that it typically is going to have this a lot of triglycerides in the core there, and you're going to have an enzyme called lipoprotein lipase. Okay, this is the main thing that's going to be starting to break down those triglycerides, and we're going to start to see things like free fatty acids being formed. Glycerol is also going to be formed as well, right? And you're going to find that they actually get taken up into the liver via these LDL-like receptor proteins, right? So again, the LDL receptor is going to be very important for the uptake and eventual metabolism of our cholesterol, right? So we're going to find that a lot of things we're doing are trying to increase the number of LDL receptors we have available in the liver, because the more that we uptake into the liver, the more we can metabolize them and get rid of them, and thus we have less chance for things like atherosclerosis to take place, as we'll see, okay? Now, what do we use all this cholesterol for? What do we use these products for? Hormone synthesis, we use it for producing new cell walls, disposal as bile salts. So we have a lot of uses for these things. It's not like they're completely useless molecules, but we're just going to be seeing how we're going to be processing these as they go along. Now, as you're looking at this picture here, you can see that the chylomicron has a pretty high amount of actual cholesterol esters and a high amount of, low amount here, and then triglycerides are going to be in the green. As you go along, you see this metabolism occur. You're going to start to see that as a higher and higher proportion of cholesterol esters. When you get to LDL, it's almost all cholesterol esters, versus when you get to HDL, it's actually just 100% that. Okay, so kind of keep that in mind as we're getting rid of triglycerides as we see more and more metabolism occurring here. All right, so moving on, then you're going to find that these carbohydrates, fatty acids, they get converted into triglycerides. And actually, when you measure a lipid panel on a patient, what are the values that come back? You see LDL, you see HDL, triglycerides. Very frequently, you're going to find that triglycerides are actually going to be measured, or basically a surrogate measurement of our VLDL, right? So again, we can convert that VLDL that we're actually measuring into how many triglycerides are actually there in the bloodstream, right? So again, there's a high correlation between there, and that makes sense based on the fact that the VLDL is mostly just triglycerides there, right? Very low amount of actual cholesterol esters that are going to be in there, okay? But basically, you're going to find these kind of chylomicron remnants are going to get further metabolized, and then they're going to get turned into the VLDL, and then they get secreted into the bloodstream from the liver, okay? Once there, you're going to find that lipoprotein lipase continues to metabolize those triglycerides, and then eventually it's going to turn to what we call intermediate density lipoprotein, which is kind of like an intermediate sort of stage before you get to the LDL. As the IDL gets removed through the LDL receptors, or as it gets further metabolized, as you get rid of more of those triglycerides, then it forms into LDL itself, right? So again, this is the one we really care about. We care about triglycerides. We also really care about the LDL, because that's our the most atherogenic sort of cholesterol molecule that we have floating around in the bloodstream, right? Now, LDL is predominantly removed by the LDL receptor. So the more of those we have in the liver, the better we're going to be able to internalize those and get rid of them, basically. So a lot of the drugs we're going to see, you're going to be focusing on those LDL receptors, as we're going to see in just a minute here. And of course, LDL receptors are also located all throughout the body, right? So again, when you need things like cholesterol being uptaken by, say, your muscle cells, or needed to be uptaken by anywhere, this is where they're going to use those LDL receptors for, or what they're using them for. And so just to give you an idea of the triglyceride to cholesterol ratio, you can see that as the chylomicron gets more and more metabolized, you have VLDL, which is mostly triglycerides, and then further metabolism here. And then finally with the LDL, it's just mostly just cholesterol at that point, right? And again, mediated through this uptake through the LDL receptor. That's the most important thing you're going to see with that, as far as getting rid of the LDL. And then eventually you have some conversion over to HDL. And like we said, that's going to be good because it helps to carry things like, LDL, the cholesterol back into the liver. And that's why it's going to be good for helping to prevent things like atherogenesis from occurring there. So anyway, and kind of showing you what one of these apolipoproteins kind of look like. Notice here you have the cholesterol esters and the triglycerides flowing around here. There's sort of a lipid layer that's going to be kind of keeping it all together, and these lipoproteins are what's going to be interacting with the receptors. Okay. So looking at the LDL, as I mentioned, they come from the IDL, right, as a metabolism byproduct thereof. They stick around for 1.5 to 2 days or so, and they get uptaken back into either the cells that are going to be kind of depositing cholesterol at, or they go back into the liver through the LDL receptor itself. Now, again, you're going to find that the LDL receptor pathway is going to be responsible for about 75% of clearance of those particles. And in fact, some patients that actually have a genetic predisposition to have fewer of those receptors, and guess what? Their cholesterol levels do. They go way high, right? Because again, they can't process and they can't get rid of those LDL molecules in the bloodstream. So anyway, most of the LDL receptors are found in the liver. Those are the ones we're going to talk about most here as far as lipid lowering therapy goes. Okay, bless you. Now again, if you have less LDL receptor activity, that means you're going to have more LDL particle accumulation, especially in things like the vascular endothelium. That means more atherosclerosis is going to occur there. Okay, again, having all those cholesterols there in the blood vessels is going to cause further inflammation, going to cause those to thicken, and then eventually they can clot off. Right, it's going to be no good. Just to give you an example of what this looks like when you have LDL receptor actions, you have LDL here. It's going to be coming in, interacting with that LDL receptor. They'll get internalized. They can then break them down, and eventually will cause resurfacing of that receptor to be used again. We're actually going to find some drugs that can actually directly affect the metabolism of these receptors. We're going to find just how effective they are a little bit later, but they tend to be the most effective ones you can actually have. Because again, if the more you have of these, the more likely you are to get rid of the LDL from the bloodstream. Okay, so here's a picture of the drugs we're going to be using to actually treat hyperlipidemia or dyslipidemia, however you want to call it. Now, does everyone know kind of what the main gold standard sort of drug class we're going to be using is? Statins, right? So again, everyone's probably heard of the statins before. Those are the big things we're going to be using here, but we're also going to find some good adjunctive agents that we can use to kind of help out and help get our lipid goals in range. Now, I will tell you, and we'll talk about the guidelines a little bit later towards the end of this, is that we used to shoot for specific LDL targets. We used to shoot for specific triglyceride targets and HDL targets. Nowadays, we're actually focusing more on the actual cardiovascular risk of the patient. Okay, and we're going to see that, and where you're going to see that really it's more focused towards statin therapy as being the cornerstone of that. Everything else can kind of be helpful. It's an adjunct, but it's not going to be really the cornerstone here. So we're going to focus mostly on the statins, but talk about the other ones as well and see how the therapy is going to go for these patients. Okay, so looking at the different groups here, we're going to talk about our HMG-CoA reductase inhibitors, those are the statins. We're going to talk about our cholesterol absorption inhibitors, fibrates, bile acids, sequestrants, nicotinic acid, and then the newest class here are going to be these PCSK9 inhibitors. We're going to go into detail on all of these later, but these are the main classes we're going to be looking at. So starting off with the statins, when you think of like blockbuster drugs, like you think of like ACE inhibitors, you think of things like Viagra, you think of the statins too, because they really make a big difference as far as like mortality goes for patients. We're going to see why that is in just a few minutes here. But again, how can you tell a drug is a statin? It says statin right in the name. That's why I call them statins, right? Because HMG-CoA reductase inhibitor is a little bit of a mouthful, so we just say statins. So you have things like lovastatin, simvastatin, Probably the most common ones you're going to run into include atorvastatin, rosuvastatin, which is Crestor, and then simvastatin. Those are probably the most common ones, the big three you're going to see being used most often clinically. The other ones are still used occasionally, but it depends on insurance, depends on several factors. So what this is going to do is basically inhibits the production of cholesterol within the hepatocytes. Okay, so you see here is an hepatocyte. We see systemic circulation here, this blue box. Basically, by inhibiting cholesterol synthesis, you're going to cause intracellular cholesterol levels to go down, right? So if intracellular cholesterol levels are going down in the hepatocyte, what does the liver want to do to compensate for that? It says, let's get some more cholesterol in here, right? So if I can't produce it myself, well, what else can I do? Well, I got a whole bunch of it floating around in the bloodstream. Let me go ahead and try to get some of that. And how does the hepatocyte uptake the LDL that's in the bloodstream? The LDL receptor, right? So again, you're going to find this is going to increase the amount of LDL receptors being actually exposed to the hepatocyte, where it's going to be able to uptake LDL from the bloodstream. Now, what does that do to your blood levels of LDL, do you think? Decreases them, right? Because again, they're all getting uptaken by the hepatocyte, so that way you can produce things like hormones, you can do things like produce cell membranes, etc., right? So that's a good thing, right? So it's by decreasing the production within the liver, you're going to try to scavenge more from the bloodstream and take it up into the hepatocyte, okay? Ultimately, what does that mean? It means you're going to have LDL receptor production of things like VLDL is going to ultimately go down. You're going to have LDL levels are going to go down, and then downstream of that, we're actually going to find the HDL levels are going to go up, okay? So if you had to expect, and we mentioned VLDLs, oftentimes get represented as triglycerides on your lipid panel. So with a statin on board, triglycerides you expect to go up or down. Should go down, right? Because again, I'm producing less of it within the hepatocyte. LDL levels you expect to go down because they're getting uptaken into the hepatocyte, and HDL levels actually end up kind of going up here. Those are all really good things, right? Those are all heading in the right direction when you have a patient with hyperlipidemia, okay? They also have a lot of what we call pleiotropic effects. Anyone know what pleiotropic means? Kind of like helpful effects that don't really necessarily have anything to do with the mechanism of the drug, but these are things that we see occurring either in studies that we're performing or whatever it happens to be. We're actually seeing that these are kind of the additional side benefits, and this is why the statins have such a strong place in the therapy of dyslipidemia in patients with cardiovascular disease, is due to these pleiotropic effects. It's all well and good to get your LDL down, but these are the things that we want to see occur when that happens. So for instance, improves the endothelial function, right? Stabilizes the plaque. Why do we care about that? The plaque can break off and then go cause a blockage elsewhere in the coronary vessels. So that's good. The more stable the plaques are that have developed, the better off they're going to be. They can do things like affect smooth muscle cell growth. Have platelet inhibition, antithrombotic effects. Again, that's another big reason why patients develop those blockages in the coronary vessels. So that's great. Things like blood pressure effects. You're going to see that it can help with ischemia, reperfusion injury that happens in heart attacks. All these are really good things, right? And so what you end up finding in these studies is mortality has a significant downtrend when you have a statin on board versus nothing. Okay, so that's the reason why, if you had to put a drug in the water, statin's probably be the one I'd probably recommend, just because it has so many extra good effects on top of just what it does for your cholesterol, right? Okay, so don't get freaked out by this table. I only show this to you to illustrate a couple of facts here, right? So again, here's all the different statins we have available to us. The big thing I want you to note, don't worry about the prodrug, don't worry about absorption necessarily, but the main thing I wanted to focus on is the metabolism here. Okay, so what do you notice about the metabolism? There's a lot of CYP3A4 you're going to see on there, right? So namely, you're going to find CYP3A4 is going to be big for atorvastatin, it's going to be big for lovastatin, it's big for simvastatin. What are the three big ones I said you see most frequently? Simvastatin, atorvastatin, and then rosuvastatin. So two of them I already mentioned are CYP3A4 substrates. That's going to be important because of drug interactions, right? So we got to be really careful with these drugs. We're going to see that these can be potentially deadly drugs if not managing the drug interactions appropriately. Rosuvastatin, which I mentioned is the other one you're going to find it gets used very frequently, kind of misses that, which is why Crestor, rosuvastatin, gets used pretty frequently. However, again, this could be dictated by insurance, could be dictated by patient access to medicine and money and things like that. So just keep that in mind that many of these, namely atorvastatin and simvastatin, have significant CYP3A4 metabolism. Okay. Other things we're looking at, so we said that, obviously LDL levels are going to go down, but what's interesting is you actually see a dose-dependent effect on triglycerides, not necessarily from the dose of the drug that we're administering, but actually from the higher the triglycerides are in the system, the bigger of a percentage reduction we're actually going to have for those patients there. So for instance, I'm giving something like 10 milligrams of simvastatin, which is a pretty wimpy dose, all things considered. If you were to have, say, a triglycerides less than 150, which is pretty good, you'd have maybe a 1% reduction. But if you had someone who had, say, a triglycerides, say, greater than 250, you actually end up seeing about a 28% reduction. So again, the more hypertriglyceridemic they are, the better effects you're going to see from these statins, which is good. Now, common side effects you're going to see with these drugs, you think, oh man, these things are great. No problems with them, we can give them to everybody. Not necessarily. There's going to be some problems with these, as we'll see. So one of these things that you may find is that these can be hepatotoxic, right? So you do worry about things like increases in liver enzymes. That's oftentimes one of the things you're monitoring for when you have them come back, say in 6 weeks after starting therapy. You want to watch for their LFTs, okay? Especially if you have any kind of inhibitors on board, they're going to increase levels of those drugs. That increases the hepatotoxicity risk pretty significantly, okay? Now, most of the time if they do have any kind of liver injury that's evidenced by the LFTs, you can either reduce the dose back down until they kind of get back to normal, or just stop therapy entirely. You may need to switch to something else. One of these other classes we'll talk about a little bit later on. Other things, you see some kind of flu-like symptoms. Oftentimes flu-like symptoms are evidenced by myalgias, and myalgias is one of the things you think about the statins pretty frequently. Now, taking the myalgia to an even kind of further extreme, you can see these myopathies that develop, again, pretty rare for the most part, and actually in some cases you may even develop what we call rhabdomyolysis. You know what that? Yeah, breakdown of the muscle. How would that manifest in the patient? How would they know they are having a problem? So, extreme muscle pain, and what is in the urine? It's cola colored. If you had to have a very descriptive term for it, kind of gets very, very dark brown because all the myoglobin from the muscles actually gets filtered through the kidneys. The problem with that is when you're breaking down muscle, you can develop a lot of acidosis from that. But the other thing is that myoglobin can precipitate in the kidneys and cause pretty significant kidney injury there. So you want to be able to prevent this whenever you can. So if you have patients who are saying like, yeah, I just felt like I ran a mile, but you see they're couch potato, they haven't worked out in the past 6 months, you say, man, my muscles are just, really, really sore after starting the statin. That'd be a good sign you probably want to do something about that. Either decrease the dose, look for drug interactions, switch them to something else, because they would be at risk for some of these more significant myopathies here. Okay, and so again, drug interactions are probably going to be the biggest source for this. So you need to make sure to look at the profile in its entirety, make sure there's no CYP interactions, make sure there's no other drugs that are going to be increasing those levels, because that's going to increase that risk pretty significantly. And we know what labs you'd monitor for, some of the rhabdo, specifically for the muscle breakdown. California Pizza Kitchen, right? So CPK would be the thing you'd be monitoring for with that one. So it gives you that sign that creatine phosphokinase would be leaching out from the muscle when it breaks down like that. Anyway, so contraindications here, if they already have pre-existing hepatic disease, probably want to avoid statins in those patients. Pregnancy, you do not want to mess with anything with like cholesterol synthesis. As I mentioned, you'll see like any kind of fat-soluble vitamins. You don't want to mess with anything with like fats. You don't want to mess with in a developing fetus because they need all of that. They're making all these new cell membranes. They're making their brain, all these things. You don't want to mess with that. So contraindicated in pregnancy, do not want to use it for these patients. We'll talk about another class of drugs that you can use safely in pregnancy, but oftentimes you may just have to have them off of this for the duration of pregnancy. As I mentioned, any drugs are going to be increasing the levels of the statins you need to be watching out for, and we'll talk about these a little bit more later on. But specifically, if I said on a test question, hey, a patient needs erythromycin for an infection, which statin would be safe to administer to that patient, right? It may have, say, rosuvastatin, atorvastatin, simvastatin, and lovastatin. You'd have to pick out and remember that, hey, erythromycin, I know it's a macrolide. I know it inhibits CYP3A4. I know it's going to be affecting statins that are metabolized by CYP3A4. I remember that simvastatin, atorvastatin, and lovastatin. Rosuvastatin is going to be the safe one there, right? So these are things that I kind of want you to be picking up on in case there's like a test question that's kind of gearing toward that. As far as drug interactions go, obviously you watch out for the CYP3A4 inhibitors. So just be aware that any CYP3A4 inhibitor specifically for those drugs are metabolized through that. Again, we saw one was metabolized through CYP2C9, not frequently used, so it's not really worth mentioning there. But if you had someone who had to be on a CYP3A4 inhibitor, something like Crestor is probably going to be a good option for them, rosuvastatin, since it undergoes so very little CYP metabolism, as you'll see there. And again, I'm not being funded by Crestor. It'd be nice. I've been calling them for a while now, but they just won't return my emails at this point. But But just know that you also find that Crestor is actually one of the most potent statins out there, and if you really need to get the LDL down, that's going to be one of the best ones out there. But anyway, so these are good examples. How about grapefruit juice? Why would that be a problem here? Yeah, so it inhibits CYP3A4 pretty significantly. So this one, they say, hey, don't drink grapefruit juice with this drug. This is one of the big ones, right? So statins, you got to watch out for CYP interactions with grapefruit juice. It also inhibits something called PGP, or P-glycoprotein. It's actually an efflux pump. Inhibiting both of those causes levels of statins to go pretty significantly. So again, be careful with that. Okay, and again, as I mentioned, these are the most efficacious, best tolerated of all the drugs we're going to be talking about in the lipid lowering goals. And actually, these are going to be first-line therapy, unless you have some other kind of contraindication to using these. These are going to be your go-to drugs for someone who has dyslipidemia. Okay. So any questions from the last stuff we covered? I'm going to go ahead and make the executive decision. I'm going to go ahead and cut off the test material at Cardiology Part 2. And you'll see why once we get through all of the antihypertensives coming up next. So the end of material will be Part 2, Part 3 and 4, and then I think Derm and I think Oncology is the last section. So it'll be, and that one's actually got an extra class session, so I have a little extra time to cover that material there. Okay. Any questions? I'll reiterate that when we get towards the end here. Anyway, so we were talking about cholesterol lowering medications. We were talking about specifically statins and how those are kind of like our gold standard. And actually, in most cases, the guidelines have moved almost to utilizing those exclusively unless there's some sort of contraindication, right? So unless you have some issue where the patient cannot tolerate it due to maybe myalgias or if they have liver disease, things like that. For the most part, statins are going to be kind of your go-to drugs. But what are the big things you have to consider with statins as far as like other medications the patient might be on? Drug interactions, right? You have to think about things like the CYP enzyme interactions. Which one was like safe to use? Had no issues really with enzyme inhibition. That's going to be rosuvastatin, or Crestor is going to be the big one that's going to be good for that. And we'll see that that is actually going to be one of the big ones recommended in the guidelines towards the end of this section here. So kind of keep that one in the back of your mind. Again, why might you not be able to use that drug? Because there's a lot of statins that are out there, right? We're going to find things like insurance is going to be a big role to play there, right? Or a patient may not be able to tolerate that particular medication for one reason or another. So think about things like, what can they pay for? What can they reasonably take? These are all going to be things you're going to consider when, prescribing for your patients there. Anyway, so the next group we have here is going to be the cholesterol absorption inhibitor. So this one is basically a class of 1. It's called ezetimibe or Zetia. And again, a lot of these drugs you're going to find in combination, right? So we're going to see like statins plus another class is a pretty frequent combo drug you might run into out there. Just like it says, it's basically trying to inhibit the amount of cholesterol that's being absorbed through the GI tract. And by that means you're going to be lowering the amount of cholesterol actually being produced within the liver. And again, when the liver has low amounts of cholesterol in it, what's it want to do? Because it needs that to form things like hormones and whatnot. So yeah, it's going to try to take it from the bloodstream, right? So again, it's going to try to liberate those LDL and try to get that cholesterol from the bloodstream there, right? So by that mechanism, you're going to be able to lower the total LDL count in the entire body, which is a good thing, right? Usually VLDL will go down as well in those cases there. So basically this one's working either through inhibiting the stuff coming into the diet. This also can help to inhibit some of the enterohepatic recirculation of things like bile salts that are going to be spit out through the biliary tract, right? Remember that was kind of our two main sources of cholesterol we're absorbing through our GI tract there. So again, kind of a dual mechanism you're going to see with that. And again, typically you want to have, when you're combining two different medications together, especially for treating things like hyperlipidemia, the important consideration to make sure you have complementary mechanisms, right? So this would be a good combination with a statin, because statins are working by what mechanism? Mm-hmm. Yeah, basically decreasing things like something, right? Eventually the LDL, right? But you have to think about things like, producing things like triglycerides and the VLDL, which has a high amount of triglycerides that are going to be located there. And eventually the LDL, right? Because remember, the lipoproteins we're going to be secreting are going to include cholesterol esters and also contain those triglycerides. The VLDL and the IDL typically have a lot of those triglycerides in there, but as they get metabolized or get deposited throughout the body, they eventually turn into the LDL, which has a lot higher percentage of the cholesterol there, right? So anyway, so that's basically going to be inhibiting cholesterol synthesis within the liver, and that's going to be able to decrease the amount of triglycerides and cholesterol you're sending out into the body. So triglycerides go down, LDL is going to go down. Eventually, HDL actually does come up a little bit in those cases. There, it's kind of a more downstream sort of effect. But so by this mechanism, if you can combine that with something like ezetimibe, you block the absorption of cholesterol, and then you're decreasing the actual production of it within the liver itself, right? So kind of a nice complementary sort of mechanism you can see there, right? You should see synergism, you should see greater drops in LDL rather than just with using one drug by itself. Okay. So again, looking at this, just decreasing the intestinal delivery of cholesterol to the liver itself, right? So those precursors can't really be utilized to help produce things like IDL and VLDL. The other thing you're going to see is due to the fact that the liver says, hey, we don't have enough cholesterol here, let's try to take it up from the bloodstream. How does the liver do that? Well, it's going to be through those LDL receptors. Remember, the LDL is basically going to be transporting that back to the liver. If the receptors aren't there, then it's not going to be able to uptake that. So that's why you're going to see increased expression there. You're taking up those LDLs and being able to utilize them for whatever purposes the liver needs. And then you basically see decreased content of those kind of atherogenic sort of particles floating around in the bloodstream. Okay. Another nice thing here is, again, you're going to find that ezetimibe itself actually gets enterohepatically recirculated, and that kind of helps extend the half-life, helps it to last a little bit longer, and helps to kind of also limit some of that systemic exposure you see there. So it can limit side effects.
I thought it was the HDLs that take those fats back up to the liver, and then the LDLs deposit them to your
Yeah, so HDL is certainly something you can try to take up cholesterol from, say, peripheral sites and deliver it back to the liver. But the other big thing you're going to find is that before the LDL deposits it, say, out in, say in your coronary vessels or the muscle or wherever it wants to go, it can also be utilized to uptake back into the liver itself and deliver those cholesterol and triglycerides there, mostly cholesterol in that case. Yeah, so either one could do that. The nice thing about HDL, why it's the good cholesterol, is kind of more like a scavenger. It's going to be kind of picking up stuff from the periphery, whereas the LDL, you can take it up by the liver before it has a chance to deposit it elsewhere, right? You get more bang for your buck from kind of trying to get that LDL down, because again, you're going to find those tend to be more atherogenic. HDL tends to not be, right? Anyway. Of ezetimibe, and here's just an example. You can see a combination of ezetimibe plus simvastatin. Again, nowadays, since statins are going to be really the gold standard, you're going to find that you're adding on other drugs if you're not really able to reach your goals with just the statins alone. So typically, you're starting off with the statin and then adding on something to that if need be, right? So we'll look at the guideline changes in a little bit. Okay, so again, looking at the effects you're going to see with this, the main thing you're going to see is some drop in the LDL, maybe a 15 to 20% kind of additional lowering when added onto a statin, which can be good. Again, those are the primary thing here. And I'll show you a table a little bit later on to see where all these different classes of drugs kind of where their niche is as far as affecting the lipid profile. Some of them are going to be really good for triglycerides, some are good for HDL. This is going to be better for just kind of getting down the LDL in addition to adding on to something like a statin, right? As you might imagine, if you have more cholesterol, kind of sitting out there in the GI tract, you may see some GI side effects associated with this. Now, does anyone ever remember that drug Ally that went over the counter some years ago? It was used for weight loss. Anyone remember how it worked? That was actually just a pure fat blocking, basically prevented fat from being absorbed from the GI tract. And so this is a little bit different, right? This is specifically just for cholesterol. This isn't blocking every single fat. Does anyone remember any of the side effects from the Ally they told you to do? They said make sure you bring extra pants with you wherever you go, because if you're blocking all this fat absorption, it's got to go somewhere, and guess where it goes? Yeah, it's going to leak out, right? So you get these really like fatty, kind of oily stools. They're like, bring dark pants. That's actually better. So like these are the recommendations. So it was not great from that standpoint. It's really good at blocking absorption of fat, so people lost weight with it. But I think it was more of an issue of I'm just not going to eat that fried food because I know what's going to happen if I do eat that fried food, and it's not going to be good for me. But almost like the antabuse we talked about, that delsulfiram, where if like I'm just not going to drink because I feel so bad when I drink. Anyway, so again, this is going to have some GI side effects. It's not that bad, right? You don't need to bring extra pair of pants with you just because you are utilizing Zetia. Otherwise, it would be a much less popular medication than it is, right? The only thing you're going to see with this, you may see some kind of additional increases in your transaminases when you have this in addition to a statin. So there can be a little bit of synergism there, not only for lowering your cholesterol, but also for trying to cause a little bit of hepatotoxicity there. As far as drug interactions go, you do want to be careful of adding this onto some of the other anti-lipemic medications we're going to talk about today. One of the big things you're going to find is with the fibric acid derivatives, which we'll talk about in a second here. You can actually end up seeing some issues with more hepatobiliary side effects. You can see increases in things like, cholelithiasis develop here just due to their mechanism, which we'll see in a few minutes, and also increases in myopathies. As far as other things, so we'll talk about bile acid sequestrants in just a few minutes here. They may actually decrease the concentration, mainly due to interrupting that enterohepatic recirculation of ezetimibe. So that could be one thing you see, maybe decreasing the effectiveness there. And then you're going to find certain drugs may be able to decrease the amount of absorption you have there. Antacids being a big one. Antacids, we've already seen, can be a big player in preventing absorption of lots of different drugs. Moving on, next we have the fibric acid derivatives. Notice we're spending a lot of time on the statins, spending a little bit less time on these other classes, and again, that just shows you the importance of these different classes. Again, they're good adjuvants, they're good adjunctive agents, but they're not going to be kind of the gold standard like the statins are. But next up, we have the fibric acid derivatives. A couple in this class include gemfibrozil, we have fenofibrate, and then this newest one is called bezafibrate or bezafibrate. So this mechanism is a little bit more less intuitive than something like it just blocks cholesterol absorption or blocks cholesterol synthesis. This is actually activating a nuclear transcription factor. So this is actually working within the nucleus itself to change actual transcription. It's activating this PPAR alpha transcription factor here. And basically what this is doing is it's trying to increase the fatty acid oxidation and will lead to ultimately a decrease in secretion of all these triglyceride-rich sort of chylomicrons, or not chylomicrons I should say, but like the VLDL and the IDLs and whatnot. So by having a decrease in VLDLs, you're going to have a decrease in your overall triglycerides, which you can measure on the lipid panel. And then eventually you're going to see this increased expression of this ApoA1, and which actually leads to an increase in HDL. So the big place you're going to see with the fibrates is it's pretty good if you have really high triglycerides, especially if you have like an isolated hypertriglyceridemia. And it's also good for helping to get the HDL up, right? So some patients, you may find their LDL looks fine, but their HDL is actually still pretty low. In these cases, this is where something could be useful because we know the HDL tends to be more protective. So you kind of want to get those numbers up in those cases, right? Another slide. So anyway, so again, if you had to think back to the mechanism increasing that PPAR alpha, that nuclear transcription factor, so you're going to see less triglycerides actually being synthesized because you have more of that fatty acid oxidation occurring there. Okay. Now looking at the effects with this, you're going to find this has a really good role to play in increasing the HDL. You're going to find this has a really good role to play in dropping the triglycerides. It's okay for LDL lowering effects, but not going to get nearly as much bang for your buck as you would see with something like a statin. Okay. Now again, typical side effects you'd expect to see with this is along with the other anti-lipemic agents. So cholelithiasis, as we mentioned, can be worsened with the ezetimibe on board there as well, and the myopathies can be playing a role here as well. As far as the contraindications go, again, we mentioned anything kind of messing with the lipid panel you want to be really careful of in pregnant patients. So most of these are going to be not recommended for pregnancy. We'll talk about again one class, but that's going to be the exception just a little bit here. Again, if you already have existing gallbladder disease, you probably don't want to poke that bear, so to speak, and make that any worse. So this would be a bad drug for that type of patient. Okay, so as far as the drug interactions go, these are one of the ones I want to note here, is that you end up seeing kind of worsened side effects from other medications that patients might be on. So for instance, a big one to play a role here is the HMG-CoA reductase inhibitors. Again, another name for the statins, remember? So again, that was the kind of the full name, HMG-CoA reductase inhibitor. But again, most people just call them statins. But again, this is going to worsen those side effects there. So it worsens the myopathies, worsens the hepatotoxicity, and in some cases, you may actually see the fibrates may actually raise up levels of some of those statins, which again can just worsen your toxicity profile. So you really want to be careful anytime you're mixing a fibrate plus one of these other statins there, because side effects are just going to get worse as the case may be. Okay. And again, as mentioned, place-in therapy, fibrates are really going to be best for patients who have either just a primary hypertriglyceridemia. So for instance, they come back and they have greater than 1,000. That's a really good role for the fibric acid derivatives. Or if they have a low HDL, you want to try and bring that up. That could be another one to play a role here. Okay. All right. Next, we have the bile acid sequestrants, or these are the resins. And so these are good. They're kind of working along a similar thought process as something like ezetimibe, where instead of just blocking the absorption, this actually is working to bind up any sort of cholesterol that's going to be in the GI tract and preventing it from being absorbed. So by binding it up, You're going to find that it's also going to be causing a lot of the drug interactions we're going to be looking at. It's also going to tell us when we actually probably want to absorb or when we actually want to take the medication. And so this one you're going to find tends to be more work better when you're taking it around mealtime, which makes sense, right? Because when is your biliary tract most active? Yeah, when you're eating, right? When you're around meal times, right? Also, that's when you're usually taking in cholesterol from the dietary perspective. So these drugs are going to work better. They also need to be given more frequently because of the fact that working around mealtime, you need to give them around those meal times. So some of the downsides of this is that you're going to find that these need to be given a little bit more frequently, and also the dosage forms we're going to see here in a second are really not that palatable to your patients. The nice thing though you're going to see with this is that it does not have any systemic absorption. Okay, all the other drugs we've talked about so far do get absorbed systemically, so they can lead to systemic side effects. So who might this type of drug be good in if it does not get absorbed at all? Pregnant women, yeah, absolutely. So like if you had children, especially if you're worried about, because again, a lot of these studies, there's not a ton of information about using these drugs in children, so that could be one place you might want to use it. The other big one is pregnancy. So if you had a patient who absolutely had to be treated for hyperlipidemia, this would be a drug class that you could utilize pretty readily without worrying about damage done to the fetus there. Okay. So as I mentioned, binds to the bile acids in the GI tract and spit out through the gallbladder, and you're going to find it's going to prevent that enterohepatic recirculation, and then just gets excreted out in the feces. Again, less cholesterol in the liver says, hey, I need to get more cholesterol out from the periphery, so it's going to express more of those LDL receptors. Again, not nearly as potent of a drop in LDL as you would see with something like a statin, but it can be useful in and of itself, just to help get that little bit of that LDL lowering effect you want to see there. Okay. Again, good for limiting the systemic side effects. Again, good for patients who do not want to have significant absorption of this medication. However, what do you think about as far as side effects go? What do you think would be the big one to think about? Probably mostly GI side effects, right? So you're going to expect to see a lot of things like flatulence and abdominal cramping and things like that. The increased amount of cholesterol out there in the GI tract. The three that fall into this category include things like cholestyramine, you have cholestyramine, and then cholesevelam. Now again, these are resins, they're binding things up. In some cases, you may actually find that these drugs can be useful for binding up other things you want to get rid of that undergo enterohepatic recirculation. There's actually a couple of drugs where if you, kind of interesting, there's a certain drug that undergoes enterohepatic recirculation that is teratogenic. And so for certain patients who want to get pregnant, we can actually give them one of these resins that will actually bind it up and get rid of it faster, so that way you don't have to worry about the drug sticking around. We'll talk about that one a little bit later on, but just know that these can sometimes be used for off-label uses, not just for hyperlipidemia.
So does this drug deposit these bile acids anywhere? Since it's binding to all of them?
Binds them up, and then where does it leave? Right through the feces. Yeah, so just poop it right out. No problem. So the things with these is that you're going to find that instead of having just like a nice little tablet that I can take one time a day or something, you're typically going to find that these are going to be in powders, because again, these are resins that are going to be binding up with the actual bile acids and coming in through your GI tract. So either these are like really large tablets like the cholesevelam can be, or they come as these powders. Has anyone ever taken like like fiber supplements or anything like that? What's the texture like? And gritty, and it's not really that fun to drink. The same thing goes for these drugs as well. They're really not palatable from that standpoint. Obviously, pills are a lot more convenient. However, these can be good though. Again, if you have a pregnant patient or someone who really just could not tolerate those other medications. Okay. Again, there's going to find that there's kind of a plateau effect you see with this. Just ramping up your dose is only going to do so much until you just see more side effects, especially from a GI standpoint. And look at that. I even did the cardinal sin of prescription writing. I wrote QD. It's no good, right? What should I have written there? Daily, Q day, every day, anything like that, right? So even I make mistakes. Often multiple a day, as it turns out. But again, usually need to mix these with things like like fruit juice or water. Oftentimes, if you mix it in something that's a little bit more pulpy, so like some pulpy orange juice or something, that oftentimes can cut down on the texture and help the mass of taste a little bit better. And as I mentioned, you want to take these with within an hour of the meal, because again, that's where your bile tract is going to be kind of most active there, right? And again, you have to separate these from other medications. That's the other big thing to know here, is that it will not just bind up the bile acids, it will bind up a lot of other medications as well. So you need to separate these out, right? So maybe you take the other medication, say an hour before the resins, or you have to wait like 3 or 4 hours after the resins before you want to take any other medications, because you do worry about them binding up, okay? Again, that can be problematic from a compliance standpoint, especially if you're worried about a patient taking multiple medications multiple times a day. You gotta be careful with that. So as I mentioned, a lot of GI side effects, mostly things like bloating, flatulence, etc. And you may even have some malabsorption of certain vitamins, like your fat-soluble vitamins. because again, those get broken down and emulsified with the bile salts. So that could be one thing you see there. And then folic acid may be another thing that gets poorly absorbed. Yes, sir.
So then, since you use it for pregnant women and they're taking prenatal vitamins and all that, and it can get malabsorption of the folic acid.
I would want to separate that out, right? So again, if I were to say, for instance, have them take their prenatal like right as they get up in the morning, and then maybe wait an hour or so before they have their breakfast, and then take the bile acids questioner with it, that would be the best thing for it, most likely. Yeah, but a very good point though. Yes, folic acid is very important for those pregnant ladies, right? Now, what's actually interesting is because you're blocking the absorption of these bile salts and whatnot, you actually end up finding that even though LDL does go down, ultimately you actually can find an increase in triglycerides. So that would actually be contraindication here. If you had a patient with hypertriglyceridemia, these drugs can actually worsen that, so do watch out for that in that case. Again, you can actually see some increased calcium excretion occurring here, and mainly that's due to binding and eventual defecation of that. So again, watch out for calcium levels, may need some extra supplementation thereof. As I mentioned with drug interactions, these will bind up all sorts of different medications. You got to be really careful. Again, these are oftentimes used in older patients and maybe on things like, antiarrhythmic drugs like digoxin, which we'll talk about later. Things like warfarin, beta blockers, anything can really bind to it. So you want to make sure you're separating those out, right? As I mentioned, be careful. Patients already have high triglycerides. These are only going to increase that further, so you don't want to worsen that. As mentioned, safest drugs overall, mainly due to the fact they lack those systemic side effects, but poorly tolerated just due to the dosage form usually being pretty copious amounts of powder you're having to take there. And again, only good for patients who really need kind of a modest reduction, and those you don't want to have good systemic absorption of the drug. Okay, up next we have niacin. Anyone know where you can buy niacin? You can buy them over the counter, right? This is actually a normal vitamin you can buy from anywhere. The one we'll talk about, there's actually a specific drug product that's going to be separate from this. So there are over-the-counter preparations you can buy versus just a straight prescription strength. We'll talk about in just a little bit. But basically, it's a B-complex vitamin. There is a form that you may find out there called niacinamide. Another name for it is nicotinamide. This is actually not going to be effective as an anti-lipemic. So you want to make sure that if you're, talking to patients and you're like, oh, I only want to take like natural treatments. I only want to, try to focus on my cholesterol. I want to take this prescription stuff. Make sure they're buying the right things, right? So give them a good education on okay, we can start off with this. You want to do niacin. Make sure you're looking for this type of niacin. If it says niacinamide, not going to be the good product for them in those cases. Okay. But it says nicotinic acid specifically. That's going to be good. That's what we use as an anti-lipemic. You can buy immediate release variety, so niacin itself comes as just like a normal dietary supplement that you can buy out there, say at the GNC or Walmart or wherever. There's one called Niacor, which is going to be a prescription strength variety. Now we're going to find that there's a big reason why we don't like to use immediate release niacin. We're going to look at why that is in just a few seconds here. Typically we like to use more long acting, and most of the supplements you find will be in a long acting sort of form. I think a lot of the immediate ones have gone away, but the one you're going to find used most frequently from a prescription standpoint is called Niaspan. It's an extended release niacin product here. Okay, there's also another form called inositol hexaniacinate. I don't see that one used too frequently, but that's also another dietary supplement you may find out there. Okay, but again, anyone know why we like to use extended release versus immediate release niacin? Yeah, the flushing is going to be the big thing you're going to see with that. So we'll talk about that. That's one of the big side effects you can see with niacin. Anyway, so the way niacin is going to be working here is actually working around the adipose tissue, and it decreases the amount of free fatty acids we're going to be able to release from the adipose tissue. Okay, so less fatty acids getting back to the liver, you're going to find you have less production of things like triglycerides, and thus you're going to have less LDL ultimately being formed here, right? So again, less triglycerides means less VLDL being produced, less LDL being produced. And the other big thing you're going to see with this is also downstream, you're going to find that the HDL is also going to be increased here. So this is another drug we're going to find this is pretty good for triglycerides, but also good for increasing the HDL. Okay, so if you had a patient with just low HDL and that was their only issue, this might be a good drug to try to bump that up. Okay. Just another picture showing the same thing. So again, decreased mobilization of free fatty acids from the adipose tissue means less triglyceride synthesis, and then downstream of that, less VLDL, less LDL, and then increase in the HDL here. Okay. All right, so looking at this, again, most of the time we're going to be focusing on the extended release products. The other nice thing about that is they're also going to be given less frequently, so maybe only one time a day versus having to give it several times a day. You don't have to know the specific dosing, but just know that's one of the benefits of giving extended release product. Now, the reason why you end up wanting to use extended release products is because with the immediate release especially, you end up getting this very severe cutaneous flushing that occurs. And this is actually going to be mediated through prostaglandins. You actually end up seeing increased prostaglandin synthesis in these cases there. And just like if you stub your toe or have an area of inflammation, what does that area do? It's very hot, gets very red, gets swollen in some cases, so you're going to find that's going to be the side effects you're going to be seeing systemically in these cases. Now, what we can do beforehand is actually we can pre-medicate with something that's going to decrease prostaglandin synthesis. And what are some drugs that can do that? NSAIDs, right, and that includes aspirin, and what else? Ibuprofen could do this. What else? Naproxen might be the other big one, right? Those are available over the counter they can use. Other things you're going to see with this is a lot of GI discomfort associated with that, especially the immediate release products. I'll tell you a quick story. When I was in rotations, I had a family practice site that I was at, and there's a couple that were in the neighborhood in Gainesville. Several clinics around the area, and so I had a couple of friends who were rotating at a different site, but we were carpooling. We were staying at the same place. We were carpooling in, and so a couple of the pharmacy students over at that site, they said we should do the niacin challenge. We just learned about this drug. Let's try it out. We're going to get some immediate release niacin, and we're going to see how bad the flushing really is. And so they decided to take a whole bunch of it one day. And so when I went to go pick up person who I was staying with, they came into the car and they were just red from head to toe. It looked like they had been just lit on fire recently. Like they were just so red, and it was miserable. They were throwing up for like the whole day straight. They were sweating profusely. It was very bad. They took way too much. Did not pre-medicate with aspirin at all. So again, I just think about that and I say, wow, even the smartest people can do the dumbest things, as the case may be. So again, that's the reason why we like to use the extended release stuff, because you end up causing a slower absorption of the niacin. You see less of that flushing that occurs there. And in fact, with the long-acting products like niacin, you really don't see it at all. But you could get someone who is more, say, prone to those sort of reactions, take an aspirin beforehand. Again, a lot of patients who are going to be, taking drugs for their lipids probably also are taking what? Maybe hypertension meds, but what else? They're worried about cardiac disease. Cardiac disease or heart disease. Maybe taking statin. Aspirin, thank you. Yes, so they're taking aspirin anyway. This is going to help out with that prostaglandin synthesis, right? So again, typically, if they're going to be more prone to these reactions, you may want to take more than just the 81 milligrams, but that's going to be something they can probably going to be taking anyway, especially if they're worried about their cardiovascular risk, right? Other things you can actually see some increase in uric acid levels. That may not be great for patients with gout or history thereof. You end up seeing some decreased glucose tolerance, which is kind of interesting. So we see that. Who might that be poor mixture with? Diabetics, right? And again, a lot of these patients tend to be diabetics as well. So again, this may not be a good option if you had someone who had a poorly controlled type 2 diabetes, right? All right, so again, do not mix this with chronic liver disease, because again, you can just end up worsening that. And then be careful with patients with things like peptic ulcer disease from the GI effects we were talking about. If they have a history of gout, hyperuricemia, diabetes, these are patients you want to be more careful in using these in. Now, does that mean that no diabetics could ever receive this drug? No, you just want to check and make sure that their glucose is pretty well controlled. You may need to adjust their meds a little bit if this is something they really needed to be on for whatever reason. Okay. Again, be careful mixing with other statins, bile acid questions, ethanol. Ethanol itself can actually worsen the flushing reaction you end up seeing with that, and then just increase toxicity with like statins and the bile acid questions there. Okay, and I mentioned place-in therapy is going to be good for patients who especially need to have some bumps in their HDL, and again can be synergistic when adding on to other medications like statins to help kind of get those levels down. But again, the focus is shifting away from all these adjuvant medications to focusing mainly on the statin effects, as we'll see in a minute. Okay, just an example looking at a combination of statin and niacin, you end up seeing pretty decent reductions in LDL, increases in HDL, which are good, and then big drops in your triglycerides as well. So again, nice thing there, but again, increased risk for toxicities, which you're going to see with those combos. Okay, so this is the newest group. This isn't something that is still very, very expensive, as we'll see why in just a moment, but these are the PCSK9 inhibitors. These are going to be typically reserved for patients who cannot get their LDLs under control with other kind of more standard sort of therapy here. So the two we have include alirocumab. What do you notice about the name right away? Yeah, it's a monoclonal antibody, right? And then we have another one called evolocumab, and these are actually injectable products. Because what do we say about monoclonal antibodies and the routes we have to administer them? can't do oral, right? Because the GI tract will just tear it up like any other protein, so you can't do that, right? So it's a monoclonal antibody. It's going to be an injectable product only. Notice how it comes like as a little pin here. Patient can administer it themselves. And so basically the way these are working is you have this PCSK9. It's actually responsible for processing of the LDL receptors. They actually help to increase the metabolism of those receptors. And we said that the more LDL receptors you have present on the liver, the better it is to try to get rid of those LDLs that are floating around the bloodstream. So basically, by trying to bind up these this PCSK9, you actually block those receptors from being metabolized. More of them are present on the cell surface, and you see very good drops in your LDL because you just have more of those receptors available to bind up the LDL floating around. And so you can see drops, 43 to 58%. Again, this is good for patients who have kind of failed everything else and they still can't get their LDL under control, but because it's very expensive. Again, these medications are always going to be pretty expensive to make just due to the more complicated nature of having a protein versus just a simple chemical molecule, right? And again, anytime you have a monoclonal antibody or injecting someone with a protein, what's the biggest risk? Not infection. You're going to find that a lot of other medications are suppressing the immune system, like when you get to rheumatoid arthritis, infection is a big risk. But with this one, this is only really affecting that processing of the LDL receptors. What's the other big risk, though? Allergic reactions, right? Hypersensitivity, anaphylaxis, right? You want to be really careful with that. This is why oftentimes you want to give the first dose, kind of monitoring them in the office, and then if they tolerate that, then you can send them home. They should be less likely to have a reaction later on. Okay. But again, with a pin like this, what do you think it could be? Maybe a hardship for a patient trying to administer? Who might have a hard time trying to use these kind of medications? Yeah, patients with arthritis or like rheumatoid arthritis, especially if they have any kind of joint malformations. So that can be tough, right? So, and again, injectable products are going to be less good from a compliance standpoint, it's less attractive as an option rather than just taking a single pill, right? So again, anytime you're using injectables, that's going to be kind of you need to have a lot of buy-in from the patient because again, it's kind of tough to have to inject yourself, say every single day or however frequently it is. So anyway, here's a good table kind of showing you the comparative effects of the different classes of drugs here. So looking at our statins, again, these are our gold standard. Looking at total cholesterol, LDL, HDL, and then triglycerides. Notice here that as far as kind of the things you want to kind of key in on, obviously LDL is going to have the best effects with statins, right? Statins are going to be kind of the best thing here. Notice, again, we're going to look at dose-dependent sort of effects here. So we're going to talk about moderate versus high-intensity statins. We'll look at that in just a few minutes. Things like nicotinic acid are going to be good for more HDL and more triglyceride effects. Similarly for the fibrates as well, right? And as far as ezetimibe, really going to be okay for getting the LDL down a little bit further, but again, not great by itself as a drug, single-use drug, right? So anyway, so any questions on that? All right, so let's look at how we got these medications. Now, when you're actually looking at your lipid panel, the total cholesterol is just going to be basically a combination of your HDL, the VLDL, and the LDL. And basically how you get the VLDL is, and I'm not going to have you calculate this on a test, it's just for your edification if you've not received this information before. But basically, what you find is the triglycerides, you can kind of use that number to try to get a surrogate for your actual VLDL count. And so basically, you take your triglycerides divided by 5, that gives you a good rough approximation of your VLDL count. And you can use that for your total cholesterol. So anyway, now, before we used to have these goals, the ATP3 was the previous guidelines we were using for a while there, and they were actually shooting for specific numbers that you wanted to reach. So, for instance, you saw that you wanted your LDL down less than 100 milligrams per deciliter. That was optimal, right? You wanted your HDL to be above 60, right? Anything above 60 would be considered very protective. Less than 40 was not being so protective, right? Nowadays, you're going to find that we're kind of moving away from getting to these specific numbers. Okay? So the newer guidelines, and this is from 2013, is they're more focusing on trying to decrease that atherosclerotic risk of cardiovascular disease associated with use of some of these medications here. So they're really trying to get down that risk, and what they find is that you get the best bang for your buck out of things like the statins, right? It's not just getting the number down, but it's also looking at things like the mortality benefits we see in studies, looking at those, remember those kind of bonus effects you get from the statins? What do we call those? Those pleiotropic effects, right? The kind of the things that may not be necessarily related back to its mechanism, but the kind of additional benefits we see once we use these in large number of patients. And so basically what you're going to find is that we're going to recommend as a first-line therapy for all patients either moderate intensity or high-intensity statin therapy, all right? So we're going to look at who those patients are going to be in just a second here. And again, we're not titrating to an LDL-specific goal. The main thing here is we're going to try to titrate to as intense of a statin dose as we can achieve in a patient. And that's generally going to be limited by what, do you think? How high can we drive that dose, do you think? What limits that? Usually side effects, right? So you're going to find that the patient is finding the side effects intolerable. They're not going to take it, so you need to make sure. And we'll see that some patients are going to be more at risk for that than others, as we'll see here in just a second. But again, the main thing you're going to do when you're looking at the lipid panel is not necessarily just to see that you got to any specific number goal, but to actually check for compliance, right? Because again, if a patient was not being compliant with their medication, what would I expect their lipid panel to do? Not change, right? If they're not taking the medication, I wouldn't expect any difference between the last time they had their panel done to now, right? Versus if I see that, hey, they had a pretty good drop in their LDL, HDL is coming up, that shows me that they should be compliant. That, or they, if something else is going on to improve that panel. So questions is, who are the 4 major groups of people who are going to benefit from statins, right? So again, the individuals with clinical atherosclerotic cardiovascular disease. What do you think that means? So patient with evidence of atherosclerotic cardiovascular disease. So ideally, it'd be like who? MI patients, right? They've already shown us they are very high risk. They've already had an occlusion there causing infarction. Who else do you might think would fit into that? Patients with angina, right? Anginal symptoms, anything they're showing you that yes, they're having an issue with this coronary vessel disease, they're going to be a biggest risk, right? Because again, we saw things like statins can help to stabilize those plaques. We saw they can really help to decrease inflammation. All these other kind of good benefits there. Other people that will benefit from this include patients with LDLs greater than 190, right? Patients with diabetes, and again, specifically more likely than not type 2 diabetes. Elderly patients or older patients, not that 40 is elderly. Lord, I hope not. But as you start to get older, again, that risk is going to be going up, as you see there. Again, looking at their LDL count. And again, if I'm going to ask you a question specifically, like what type of statin therapy should they need, I'm going to make it pretty clear. Like I'm going to say, hey, patient just had a heart attack yesterday, right? Yeah, they're pretty at risk for developing further cardiovascular disease, further cardiac mortality. They're going to benefit from the statin, right? And then the other big thing they're looking at is not only patients who have developed cardiovascular disease already, but what's their risk going forward, right? And so I'll show you a calculator you can use for that. But basically, if they say that, hey, you have a 10-year risk greater than 7.5% of developing cardiovascular disease, then you would also be a potential benefit from statins as well. Okay. So let's look at that. Again, looking at the kind of the decision tree here, you're kind of looking at say, okay, well, they had a heart attack recently, or they or a history of heart attack or angina or things like that. You're looking at this, okay, well, yeah, they're definitely going to benefit from here. So then the question is, well, what do I shoot for? Do I try to go for a more moderate intensity statin, a high intensity statin? Very frequently, it's going to be dictated based on what the patient can tolerate. Older patients, especially once you get above things like 75 years of age, they tend to be less likely to tolerate those high doses of statins. They see more myopathies, they see more hepatic injury. So because of that, you typically want to shoot for a little bit lower doses. Okay, I'll show you a table that kind of compares these together in a little bit. But less than 75, you want to shoot for as high intensity statins as you can get, right? Because again, it's not just the numbers, but it's all the extra benefits we get from those statins. Okay. Now, if they don't have any history of ASCVD, then you're going to be looking at their LDL concentration. If it's greater than 190, then yeah, they also would benefit from statin therapy. Those are also going to benefit from the high intensity number, because again, 190 is pretty high. We want to get that down lower than that. Then going down, they have diabetes, because again, diabetes is a big risk factor for cardiovascular disease, right? So again, this is one of those things where again they would also benefit as well. And again, very frequently you're looking at things like what's their risk, right, over the 10-year time frame. It's greater than 7.5%, then definitely they're going to get some benefit with that. And then if they didn't have diabetes, and you go down and look at what the risk is in total, and I'll show you the calculator in a second, they would also potentially benefit. Okay, so what are the things you think go into that 10-year risk? Some things that may predispose someone to developing a heart attack. So yeah, family history could be one thing. Yeah, smoking is a big one. Smoking is huge, right? Their blood pressure. If you were to look at a calculator, again, gender can also play a role here. Who do you think is more at risk? This thinks to be a guy, right? Just kidding. Yeah, so male tends to have a little bit higher risk there. Systolic blood pressure, obviously the higher that is, the more likely you would think that it would be a risk factor there. Are they on treatment for blood pressure, right? And that would, even though they may have a normal systolic blood pressure now, but they're on treatment for it, that is a risk. They have diabetes, they're a smoker, and then their cholesterol, and then their HDL, right? Race can also play a role here as well, along with age. So you put all this in, and again, I'm not going to have you calculate it specifically, but you put all this stuff in, and then it will pump out basically a number. It says like, hey, here's your 10-year risk for developing, atherosclerotic cardiovascular disease over the next 10 years. And so based on that, if it's high enough, say greater than 7.5%, that would usually indicate the person would probably benefit from having a statin on board, right? So just to give you an idea what this would look like between high, moderate, and low, typically for most patients you want to shoot for high intensity whenever you can, unless they are elderly, so greater than 75. You definitely you want to be a little bit more careful with them, or if they just can't tolerate the high intensity statin, that's when you're going to bump them down. And again, specifically, I'm not going to ask you, which dose of atorvastatin qualifies high versus medium intensity, but I do want you to recognize at least here the two drugs that fit into the category of being the most potent and thus the highest chance to actually have that really high intensity sort of effect here. Notice here we have rosuvastatin, which is Crestor. You also have atorvastatin, which is Lipitor. These are the two most potent statins you're going to run into. They're going to get the most bang for your buck out of these drugs here. Okay. Everything else kind of falls into the moderate intensity statin sort of category here. Notice you can just use lower doses of rosuvastatin or atorvastatin to get the same moderate intensity sort of effect here, but just know kind of everything else really kind of falls down either in the moderate or low intensity. These are the two big ones you're going to get the high intensity sort of effect from, okay? Crestor is the most potent, atorvastatin's the second most potent, okay? Makes sense? Because again, potency, I said, what's the importance of potency? Yeah, how big of a dose I need to get that effect. So again, these are very, very potent. So I need not a whole lot to actually get very good effects as far as from a lipid standpoint and from my cardiovascular risk, okay? So anyway, so as far as your patient, you want to select the appropriate dose based on whether any high, moderate intensity statin effects. Remember drug interactions, right? What was the other benefit from using Crestor or rosuvastatin? No CYP enzyme interactions, right? It's a non-CYP mediated metabolism, so that's the other big benefit there. But again, if my patient can only afford atorvastatin because it is what's covered by his insurance, then I'm going to try to find another way to get around the CYP interactions if that was a concern there, right? So keep those in mind. Again, if the high or the moderate intensity is not tolerated, then you're going to just kind of go down to the maximum tolerated dose possible, right? So again, if they come back and their LFTs are starting to increase, that'd be something I want to try to back down off the dose and try to find something where they're going to have a good stable effect without trying to damage the liver any further, or they don't develop myopathies, etc. Okay. Okay. So any questions on that? Fantastic. Let's do a 10-minute break. We'll come back and then move into the hypertension meds.